We will continue our discussion, which we started from a pregnant patient, which every anesthetist is facing daily in different scenario, like a pregnant patient for any non-obstetric surgery, or a pregnant patient with some complication for obstetric surgery. Okay, so we covered a massive obstetric hemorrhage. So today my aim is to discuss with you pregnancy-induced hypertension. Okay, what do you mean by this pregnancy-induced hypertension? Can anyone just tell?
Sir, this is defined as the systolic blood pressure of more than 140 or diastolic blood pressure of 90 after the 20 weeks of gestation. Okay. And usually it is accompanied by proteinuria and protein of more than 300 milligram per deciliter.
Okay, so I think you are mixing it up with preeclampsia. So what is pregnancy-induced hypertension? Yes, anyone else can clarify this?
Sir, the pregnancy-induced hypertension is the hypertension which is there after 20 weeks of gestation. Only.
What about if it is occurring before 20 weeks?
Then it is not pregnancy-induced hypertension, sir. And this
what is
it is hypertension with pregnancy.
What is another word for it?
Hypertension, pregnancy what should I say?
Chronic hypertension or preceded pregnancy, sir.
What is gestational hypertension? Have you heard of this terminology, gestational hypertension? Anyone else can want to comment on it?
Hypertension started with pregnancy. But I mean, preeclampsia, it is not only hypertension. Hypertension plus hypertension with edema, with proteinuria. But yes, when we talk about gestational hypertension, it is only hypertension. It started with pregnancy. I mean, it is not chronic hypertension before pregnancy and exaggerated during pregnancy.
You are quite right.
New diagnosis.
Yes,
new
you are
diagnosis
quite
during pregnancy.
You are quite right. If it is without any features of preeclampsia, it is, and after 20 weeks, it is gestational hypertension. Okay, and if it is occurring after, before 20 weeks, so they will say chronic hypertension in pregnancy. Okay. Okay. Usually these terminologies, because some of the people maybe who are listening may be appearing in some SAQs, exams, or other pattern. So maybe they can be asked about these definitions. Okay. So if we just elaborate further, what is preeclampsia? What is preeclampsia?
Sir, as I missed earlier, this definition earlier. Preeclampsia is usually defined as the systolic blood pressure of 140 and diastolic blood pressure of 90 mmHg after 20th weeks of gestation, and that is usually accompanied with the proteinuria.
Proteinuria. Okay. So, like, how will you quantify proteinuria?
It's more than 300 milligram per day.
And so they are doing 24 hours this urinary protein, or what?
Yes, or 3+ proteinuria.
There is some other parameters which I don't have much idea about it. If someone has got these terminologies are like urine protein over creatinine ratio, okay, and albumin creatinine ratio.
Is
Okay.
dipstick, sir, dipstick method.
No, this is
And
not
protein creatinine ratio greater than or equal to 0.3.
Yes, protein creatinine. Yes, Dr. Jasim.
We can consider preeclampsia as high blood pressure with end organ damage associated with other organ damage like liver, kidneys, and usually start during the 20th week of pregnancy.
Yes, yes. According to the level of organ dysfunction, we will classify it into, like, if it is like a massive organ dysfunction, so it will be severe preeclampsia. Okay, like which organ system will be involved? As you told, that involvement of kidney leading to acute renal failure with the high creatinine. Okay, and liver enzymes will be raised, and there may be even hepatic rupture. Okay, there may be right hypochondric pain, and then other than fits, other than like epileptic fits, other than that, any neurological problem like headaches, diplopia, altered mental status. Okay, and
This termed HELP syndrome.
yes, severe. Yes, what is okay? Who will tell what is HELP syndrome? Dr.
It is associated with hemolysis, elevated liver enzymes, and low platelets.
Okay, so it is a severe form of preeclampsia. Okay, okay. So like actually I chalked out some of the questions, so I would like you to have a look. I shared in the group as well. So we will just, okay, what is the pathophysiology of PIH? How and why this pregnancy-induced hypertension occurs?
So there is the physiology of the preeclampsia, or rather I would say pregnancy-induced hypertension is, there is one in vascular dysfunction of the placenta. There is imbalance between thromboxane A2, elevated production of thromboxane A2, and decreased production of prostaglandin 1,2. That is a potent vasodilator, and thromboxane A2 is a potent vasoconstrictor, and also promoter of the platelet aggregation.
Okay.
And second one is the endothelial dysfunction. It reduced the production of nitric oxide, and so it because of the endothelium 1 production, increased production of endothelium 1 cause activator of platelets and vasoconstriction of the vessels. Number third is the marked vascular activity and endothelial injury. It is also imbalance between reduced placental perfusion, which can lead to systemic manifestation of the hypertension, sir.
Yes, actually, if you just summarize it in even further to the point, compact words, it is because of abnormal placental implantation. Okay, and this is one thing. Number two, there is imbalance between vasodilators. Forget about the names. There is imbalance between vasodilators and vasoconstrictors. So vasoconstrictor function is thromboxane A2 is increased, while prostacyclin function is decreased. Okay, and at the end, this endothelial dysfunction, and then you decrease activity of nitric oxide.
Sir, further, sir, because of the decreased production of prostacyclin and increased production of thromboxane, it caused the placental perfusion, which caused the release of uterine renin, which converts angiotensin to angiotensin 1, angiotensin 2, and further vasoconstriction and the hypertension, sir.
Okay,
And
if
also,
someone asks you this question for you specifically, and any other people who are going for oral part, if they will ask you what is the pathophysiology of PIH, don't go in too much details. Okay.
okay.
If someone knows about it, they will twist your neck. I tell you, the simple words are more than enough. You don't need to tell 5 pathophysiology. This question will be only for 20-30 seconds in your scenario. So you don't need to do PhD in pathophysiology. Okay. The simplest of the answer which I told you. No need for going in too much detail. Okay. This
I usually make a short answer as a micro thrombosis, microemboli.
Yes.
That's why they give a prophylactic aspirin to counteract the effect of these microemboli.
Yes, actually, when there will be increased activity of vasoconstriction, like increased vasoconstrictor activity, there will be stresses, and even pregnancy or itself is a hypercoagulable state. Okay, so sometimes they will, when they are giving aspirin, even in other patients who are obese in pregnancy, so it is also among the risk factors. So it is one of this response will be exaggerated. Okay, Dr. Atik. So if someone asks you what is the pathophysiology, you just remain simple. Abnormal placental implantation leading to imbalance between vasodilator and vasoconstrictor and resulting in the pathophysiology. Okay. So okay. So just tell me one thing, that this is something new which I found in some of the article. What is the role of this uric acid and placental growth factor? Does anyone knows about it? This is some growth factor which is released by the placenta, and it is a marker. If its level is decreased, it's some sensitive predictor that there are more chances of getting preeclampsia isolated from, because this will occur before development of hypertension. Okay. So I just read about it. And what about uric acid? Uric acid, similarly, that is in the start of pregnancy, there is actually slightly decrease in uric acid level. But if it is persistently increased, it is also a marker of PIH. Okay. Rest of the clinical features and urine RE, we know, everyone knows about it. Edema, increased protein loss, and the clinical features in the various organ systems. Okay. So this is what you should be knowing. They will be asking you about the diagnostic criteria. You use the word, Dr. Atik, this dipstick method. This is a crude way. Exactly is the one which we discussed, 300 milligram or more than 5 gram in case of severe preeclampsia. Okay. And then this one, systemic effects, we discussed that in all different organs system it will be there. Okay. So what will be the some other associated question which you should be knowing? What will be the effects of PIH or this preeclampsia on this different things which you are dealing? So one effect will be on the baby. Okay. So there are more chances of IUGR and everything. There will be some maternal complications which can occur, is specific to the obstetric history, and other than that, development of abruption and IUGR, and these all are related to PIH. Am I right?
Yes. Also, hepatic coma, hepatoencephalopathy.
Yes.
And which carries a high mortality rate.
Yes.
To the mother.
Yes. Patient can go in preterm labor. Patient can have IUGR. Patient can have more chances of fetal distress. Okay, so these are the things which you should be knowing. Okay, what are the goals in the management of PIH? Like if someone asks you, you have a patient with PIH, what are the things which you should be targeting, Dr. Atik?
Sir, the goals are to control the blood pressure.
Very good.
And sir, to prevent the end organ damage, and sir, to optimize the fluid, and sir, to optimize the placental perfusion, sir, and sir, to provide the labor.
Again, listen. When we are pinpointing it, like pregnancy-induced hypertension, or to be very specific, this preeclampsia, one aim is control of blood pressure. Number 2 aim is control of or prevention of fits. Okay, like if it is preeclampsia, you will not let it go to eclampsia, because the difference between eclampsia and preeclampsia is fits.
It's only fits. Sir, okay. I told sir, to prevent the angle damage, like to prevent the seizures, to prevent the intracerebral bleed, and to prevent the ischemia of the heart, sir.
No, that is to be very specific. Number 1, control of blood pressure. Number 2, control or prevention of fits. And there is the third thing. What is third thing?
Sir, to the safe delivery of the baby, sir.
Delivery of the baby. Okay, with priority to the mother. As much as baby can be developed, but if there will be certain conditions in which if the life of mother is in danger, they have to abort the baby. They the consideration. This will not be your decision. This will be a multidisciplinary team decision. Okay, but preeclampsia will not be treated, or eclampsia will not be treated till the time baby is delivered. Okay, so the ultimate management of preeclampsia or eclampsia is the delivery of the baby. Okay.
Baby.
Okay, so like I just talked out, just named here pulmonary edema. If pulmonary edema occur, what will you do? If CV occur, what will you do? If heart failure occur, what will you do? If bleeding occur, what will you do? Like coagulopathy, hepatic, these are the things which actually you know about it. So there is nothing rocket science in this. If there is CVA and the increased conscious level, you will be maintaining the airway, and you will be controlling the blood pressure. You will be giving the multidisciplinary team, and you will be involving the neurologist. Maybe intervention and radiologist is needed, neuroradiologist. Heart failure, you will be treating the heart failure as you treat in any other patient. Okay, so like this is you should be knowing, because they can ask you separately as well. So if you have a good concept, you will be able to. But how to treat coagulopathy? What should you do? How will you quantify the coagulopathy? Dr. Atik, how do you quantify coagulopathy?
Sir, coagulopathy, we have to, sir, sir, so what do you want to ask, sir? How to treat the coagulopathy?
There is a patient with coagulopathy. Okay. So okay, first of all, how would you say that patient is having any coagulopathy?
Sir, first of all, I would say by the coagulation profile. We will look for the coagulation profile, sir.
History.
By
history. Maybe patient will start having bleeding from somewhere.
Right.
Okay.
Start from the history.
And then you might see something, and then you will go for investigation. Okay.
Sir, history and examination, then investigation.
On history, what investigation you can see?
Sir, we can see coagulation profile overall. We'll look for the PTK, and sir, INR,
platelet count,
and sir, CBC as well, sir.
CBC has relation with coagulopathy.
Sir, we can check for platelet in complete picture, sir.
Is DIC a coagulopathy?
No, sir. DIC is coagulopathy, sir.
Exactly. Yes, DIC is a coagulopathy. Okay, so how do you, what test you do for DIC?
Sir, it is the D dimers,
FDP and D dimers. Okay.
FDP and D dimers.
As we mentioned before, that there is microvascular thrombosis. So this is the thing which is occurring. Okay. Actually, this question, why are you confused? Because this question usually will not be asked in PIH. Okay. But this is just your brain exercise, that if coagulopathy is occurring, coagulopathy is coagulopathy because of any reason. So you will be looking at some clinical features, and then you will be doing some investigations. Okay. And the other thing which you can do is, if in specific scenarios, you will be targeting the scrotum or thromboelastography. Okay. Because coagulopathy in PIH you can face during the cesarean section. Actually, that patient have this underlying situation. Okay. And maybe you gave regional anesthesia. We will just discuss this point shortly, that you have given regional anesthesia and now patient develop epidural hematoma. Okay. So this is also the cause of coagulopathy. So this is also part of your management. What will you do if you give epidural to a patient with preeclampsia? You see the numbers were good, and you give epidural, and now there is epidural hematoma. First, what will you do?
First of all, sir, I will call for help and stop the running of the whatever the fluid is going on. Second, I will call for help. Then ABC, airway breathing and circulation.
Epidural hematoma, Teek bhai, please relax.
Sir, first of all, I will
what will be the features? This is actually, we are going a little bit distracted, but this is just for brain exercise.
Sir, first of all, if somebody, we have to evaluate between two things. If the bolus has been given between first or 2 hours, then it may be the drug effect. Or answer, if the patient is not moving her feet.
Just a second. I have to interrupt you. You are going wrong. What is the problem in epidural hematoma? There will be some neurological involvement. Okay?
Sir, may I reply, sir? Actually, there will be a pain, and there will be because of the pressure effects of hematoma, there may be a sensory or pain in the related effective area.
Like you better notice that there will be some neurological involvement. Okay, pain is not necessarily. Sir. Pain is not necessarily. Okay.
Pain or sensory, even different, any tingling or whatever. The
neurological involvement.
You're right.
Okay, and then immediately you will be calling the neurosurgical intervention by ordering the MRI and neurosurgical intervention. If you are suspecting epidural hematoma, immediately you have to proceed in that direction. Okay, so actually this is not part of it, but actually this is how we should be learning. Okay, why? That's why.
Sir, I have a question.
Yes.
Sir, if 1 hour before bolus has been given to that patient, and sir, if he is not moving, like, will we not to wait for the 1 or 2 hours just to distribute the effects of that, if it is because of the drug effect, or if
you are absolutely right. I am honoring this comment of you. This is you are absolutely right. But the thing is that usually epidural, which sort of dose we are supposed to give?
We have to give analgesic dose, sir, 0.1.
So analgesic dose will cause motor loss?
No, sir. But
so of course, this is understood that you will be ruling out the dose, and then if there is some persistent neurological involvement. Okay, this word neurological involvement is a broad term. Okay, so it has everything. So that's what I was about telling. Your point is absolutely valid. Okay, so this is just in between. We went a little forward. Okay, so how to control blood pressure? Before that, I would like to ask you this question. Why fits occur in PIH? Who will answer?
Actually, it's
your question, what is
compromise in cerebral blood flow because
Okay.
of its occurrences.
Any better answer? Raja Nand, would you like to say something?
Sir, due to increased blood pressure, cerebral edema, and
Okay, cerebral edema and
it may lead to intracerebral bleed and fits.
actually intracerebral bleed, if it occurs, it is beyond fits. Okay, it is now that will be causing CVA. Fits occur because of this vascular. Fits occur maybe because of cerebral edema and increased ICP. Yes, Arsalan, would you like to add something?
Yes, sir. Due to, I think, cerebral vasoconstriction,
Yes.
which ultimately lead to ischemia and massive neural discharge, and which lead to fits.
Like fits. Why fits occur in head injury? Head injury.
Electrolytes.
Yes. Like yes, electrolyte is one of the reason. Electrolyte imbalance is one of the reason. Usually it is because of any ischemic change or anything which is increasing the ICP. Like there are so many reasons for fits, but usually it will be the multiple reason will be any electrolyte imbalance, any increase in ICP. So in this PIH, usually it is because of vascular problem. Okay, because of vascular insufficiency, this ischemic, this fits will be occurring. Okay. So what will be the complications and sequelae for fits? What will happen when there is fits are occurring? Again, Atik, Dr. Atik, please answer this question.
Sir, there will be fits. We can lose the there is risk of aspiration and the irritability of the whole body.
Like and aspiration, any injury, any fracture, tongue bite.
And it is because acidosis, respiratory acidosis, because of that all things. And sir,
fetal compromise.
Fetal compromise, fetal perfusion, impaired fetal perfusion, and fetal bradycardia, fetal arrest, and sir, multi-organ damage.
Okay, so now these two questions will be together. What will be your target for the? What are the different options, first of all, for the controlling of blood pressure and prevention or control of fits? What are the different group of medicines which are being used? What is the first choice for blood? That this is a question which is being asked number of times, and you are unable to pick it out whether the answer is magnesium, whether the answer is labetalol, whether the answer is hydrolyzing. Am I right? These questions all of you will be facing. Doctor, yes, Arsalan.
Sir, if it is hypertension emergency above, then we have the choice of hydrolyte. And if there is fits, then of course we will give magnesium sulfate or 4 milligram stat and 2
4 gram. 4 gram.
And 4 grams, sorry sir. And otherwise, if there is no fits, then our choice is labetalol.
No, but if there is no fits and there is high blood pressure, would you like not to give magnesium to prevent fits? Because if there is high blood pressure, fits are inevitable. Fits will occur. So first,
magnesium is always given as prophylactic.
Yes.
Also.
Yes. So magnesium is also, so in MCQ, it's a very tricky, and it will be according to the scenario which they have asked you. It can be labetalol, it can be magnesium, according to what they are asking you. Okay. What will be the first thing to do? What is the most appropriate thing to do? This is actually I wish that I may not to be attempt these questions again, because actually sometimes it's really difficult to pick it out whether they want to ask magnesium or labetalol. For the people who are sitting in any written exam or in oral part, it's very easy to tell. They can say that they have to use both magnesium and labetalol. Okay, but in MCQ it's sometimes very hard to pick it out. But usually the drug group which they are used are in pregnancy-induced hypertension. What is the first drug they use usually?
So mostly it is
labetalol. Labetalol, sir.
Labetalol or methyl dopa?
Labetalol, sir.
Just a second. If it is not emergency, they usually these patients are on regular methyl dopa. Okay. And then if it is an emergency, like we discussed, then you have to give boluses of labetalol or hydrolyzing. Or still, if it is not controlling, then you will take arterial line and you may need infusion of
nifedipine or
yes, okay, nifedipine or nitroprusside according to the scenario. Okay, so you there is the first choice I think is labetalol among the antihypertensive, and hydrolyzing is also being used. What is difference between labetalol and hydrolyzing in clinical effects? Yes. What is difference between labetalol and hydrolyzing?
Sir, hydrolyzing is an arterial dilator, sir.
And labetalol?
And labetalol is a beta blocker, sir.
Labetalol is beta blocker? No.
It is alpha and beta both.
Alpha
beta blocker. Okay. So what will be the disadvantage of giving hydrolyzine, which will not be there in labetalol?
So tachycardia reflex.
Yes, there will be less chances of reflex tachycardia, which will occur in hydrolyzine, or if you are using any alpha blocker. Okay, because hydrolyzine is directly acting vasodilator, and labetalol has some beta blocker effect as well. More predominant, it has more of alpha effects, but it has beta effects as well. Okay, so it will cause both alpha and beta blockade. Okay.
If the patient is asthmatic, we could also avoid it.
That time, in that scenario, still, you see, you are absolutely right that whether you should be giving in that scenario, maybe you can use hydrolyzine, okay, or another medicine, nifedipine. Okay.
Is there any role for nitroglycerin in this case to control hypertension?
Actually, nitroglycerin, because just tell me what will be the disadvantage of using nitroglycerin?
Fetal cyanide toxicity, sir.
Okay, what else? Because nitroglycerin is very short acting. Okay, so you need an infusion. You cannot give like one dose and the so it needs to be monitored, and it has to be given slowly. Number one, and number two is that actually nitroglycerin is not primarily antihypertensive. It is primarily coronary vasodilator. If you are talking about any nitrate, it is nitroprusside, which is predominantly arterial vasodilator. And in the pathophysiology of PIH, we discussed that there is vasoconstriction. There is widespread vasoconstriction. So the thing which you are needing primarily is the vasodilator. Okay, and nitroglycerin is primarily coronary vasodilator. Yes, it has some venodilating effect throughout the body, but primarily its selling point is coronary vasodilator. Okay, so if there is element of pulmonary edema, it is a better choice, because what will it do? It will reduce the what will be the advantage in that scenario? It will reduce the pulmonary pressures. Okay, because it has effect on pulmonary pressures. That's why, but when we use in patient having pulmonary hypertension and you are using nitroglycerin, okay, sometimes if the patient is in heart failure, you will be surprised, the people who do cardiac, if when they are using nitroglycerin in a patient with heart problem during CABG, actually blood pressure increase when you give nitroglycerin. Okay, so maybe till the time I had not conducted cardiac anesthesia, I was unaware of this effect. And when I practically saw it, now I never use nitroglycerin to start with any antihypertensive, like as antihypertensive. Okay, So this is, but in the practical scenarios, because nitroprusside can cause severe hypotension, so for that it is mandatory to have arterial line, okay, and it can cause sudden severe hypotension. So still nitroglycerin can be used in that scenario in our general practice, okay. Okay, so
Excuse me, sir. One thing more I want to add, if you will correct me, sir. The hydrolyzing has a very speed. It depends upon the speed of onset. It is given in 5 milligram IV in over 20 minutes, then in and for 20 minutes per hour infusion, sir. If you give labetalol, you can give incrementally. This will decrease in a short period of time, and you can't give atrazine in a single bolus time, sir.
yes, yeah, these are details. Actually, yeah, you are absolutely right. Hydrolyzing will get its effect earlier, but labetalol also, I think it is comparable for its effect. Am I right? Or no?
No, sir. Atrazine, if you give very fast, then the patient can go in profound hypertension. And the labetalol, you can give boluses. The patient will remain stable, not profound hypertension, sir. I want to say that.
I think you should not use this word. It will not do this, okay? Because again, it's not required, Atik bhai.
Okay, sir.
For you specifically, because you are going for oral exam, so you should not dig yourself in this grave. I don't think so there will be any scenario in which they will ask you whether you will give labetalol or hydrolyzing. You will just say that labetalol will not cause reflex tachycardia, while hydrolyzing will cause. And I don't think so they will ask you so many details. Okay.
Okay.
Okay. So what about magnesium therapy? How will you monitor magnesium therapy? What you should be doing when you are starting magnesium therapy?
First of all, sir, in magnesium therapy, we will give 4 gram of IV over 20 minutes.
Would you like to do something before that?
We will check the magnesium level, sir.
You will send the magnesium level. You will check whether patient urine output is coming or no. Okay. This is something extra, but you should be knowing this thing. Of course, in the in emergency scenario, when patient is having eclampsia or preeclampsia, you will start it. But this thing should be in your consideration, yeah, that you will have to monitor the drug level, and you will be look at the urine output.
Especially for those who are using the digitalis or adrenaline, etc. Then they are very important to monitor the magnesium level, sir.
Okay. So, what are the therapeutic levels? At what level neuromuscular problem will occur, and then respiratory, and then cardiac. Okay. So you should be knowing the levels. In what is the SI unit? SI unit is millimole per liter. Okay. But because I never remember it, but I think millimole, then double is milliequivalent, and then double is milligram per dl. Don't quote me, okay? You just confirm it, because I never recall it, I never memorize it. But you should be knowing at least one units. You should be knowing the units which is associated, because the levels are different. But usually there will be certain therapeutic levels. Then after, if you are exceeding therapeutic level, neuromuscular problem will occur, which you will monitor by deep tendon reflex, then by respiratory insufficiency, and then cardiac arrhythmias can occur, okay? And cardiac toxicity, this will be the at the highest level, okay? So you will be, actually I have written everything here, which I am telling you. And this is another question: when to stop magnesium therapy? When will you stop magnesium therapy actually?
Sir, when the blood pressure is, normal.
No.
And sir, there is no fits. Blood pressure is normal, and sir,
blood pressure normal is not the criteria for stopping magnesium, Atik.
24 hours from the last seizure?
Yes, 24 hours after the last seizure. You have to continue it till 24 hours after the last seizure, or or after how
Or
much time
after
after
control
delivery?
of blood pressure, diastole less than 110.
Actually, to be very specific, magnesium level is not for controlling blood pressure primarily. Okay, magnesium therapy usually is to prevent fits. Yes, when you are using magnesium, blood pressure also falls, but that is primarily for the prevention and control of the fits. Okay, so magnesium, as you told, that you have to continue it 24 hours after the last fit or 48 hours after delivery. If I'm not wrong, please correct me. Arsalan, you were saying something.
Yes, sir, the same thing you just mentioned, but sir, I also want to know, is magnesium also lower down the blood pressure, or we just give it for seizures?
No, magnesium also has vasodilator effect. It has membrane stabilizing effect. It reduces the it blunt the stress response. Okay, so that's why these are the things which you have not to know about role of magnesium therapy in management. Okay.
It is a tocolytic agent as well, sir.
Tocolysis, yes, tocolysis, it's an isolated effect, but we are not giving magnesium in a PIH patient for tocolysis. Okay. These are the other effects which will be coming. And what are the interactions of magnesium therapy?
Or if there is magnesium toxicity.
Okay, what toxicity? Please say it again.
If there is signs of magnesium toxicity, we have to stop magnesium infusion.
Okay, this is one thing. What else?
Sir, it increased neuromuscular blocker effect.
Okay, so you have to reduce the dose and you have to monitor neuromuscular block in nerve stimulation. Sorry, neuromuscular stimulation, because it will prolong. Okay. What else, if it is given, can cause more problems? I think it is lithium. Okay, and what other antibiotic? There is some antibiotic aminoglycosides which can also increase the neuromuscular weakness. Okay, if you have happened to use them together. So here we have missed one question. This what are different options for controlling of fits? In addition to airway, breathing, circulation, airway, we have to manage it. And then what else other than magnesium for the control of fits?
It is
midazolam,
and sodium.
Okay, benzodiazepine. What else? What about
phenytoin, propofol?
Yeah, just a second, please. Thiopentone. What else? Yes, Rajanan.
Sir, I could not hear you kindly.
Yes, my question is that other than magnesium therapy, what option you have to control the fits?
The propofol.
Thiopentone, propofol. What else? What about the other antiepileptics? Phenytoin can be used or no?
So never heard of phenytoin.
If it is not controlling by any other way, you will have to add
then,
it. Like
then
you have to treat it. Yeah, it will not be in first line. Okay. I was expecting to say that it is teratogenic, but after 20 weeks, there is no element of teratogenicity. You have to control because you see there is a baby and there is a mother. You have to give priority to mother. Priority is to mother. Yes, you have to discuss with the surgeons and everything that you have to prolong the pregnancy as much as possible, but the priority is for mother. Okay. Okay, now this challenge between some of the points about comparison between GA versus spinal versus epidural. So what are the advantages of GA? Azhar, would you like to tell, please? What are the, Azhar is here or left? What are the advantages if you are giving general anesthesia? Atik bhai?
Sir, if there is contraindication to regional anesthesia, we have option of GA.
First, I'm sorry, Raja, I will interrupt your answer. First of all, try to tell the advantages of GA rather than starting like a mother-in-law for regional.
Sir,
You understand?
could I do?
Just
Sir,
a second. Let me give him a chance, Rajanand. What will be the advantages of GA? Just think logically. There is control of airway. This is for any patient when you are comparing GA versus regional. So this is the thing which nobody can say no to you. Okay.
Sir.
This is one thing. Number two, better control, overall control of
hemodynamics.
Because these patients, I was about to discuss this thing in fluid management, because these patients are volume depleted. Okay. So there is better control of hemodynamics and airway control. This is the number. These are two important things, and three things that it is better to control, easier to control fits with GA rather than with regional, because you cannot control it with because the agents which you are using for general anesthesia, they have some
are also antiepileptic.
Okay. So now the Ateek bhai, question to you: what are advantages of regional?
Sir, in regionally, sir, it is a better control of the excessive surges in blood pressure, avoidance of the airway manipulation.
Again, restart. What are advantages of regional?
Sir, in regionally, there is a better hemodynamic control in blood pressure.
No.
Blood pressure, sir, especially in preeclamptic patients, sir.
Okay. Partly accepted. In specific, blood pressure will fall. Okay. Actually, there is risk. If you are giving spinal, what will happen? There will be sudden hypotension, exaggerated hypotension. That's why in other patient, if you are not preloading, you have to preload it even with colloid, because you have to be very meticulous about the fluids. You cannot give too much fluid, because there is endothelial dysfunction. There will be more chances of patient having edema. Okay.
Sir, second, sir, it is the avoidance of polypharmacy.
This is the disadvantage of GA.
Or sir, it is sir, it is the post-operative pain relief. No, sir,
this is not the first thing. First thing is that you reduce the stress.
Avoidance of the airway, sir.
No, stress response overall, not specifically airway. Okay. You are avoiding the stress response. You are blunting the stress response. The stress response is culprit for causing embolism. Okay. So when you are giving regional anesthesia, there is less chances of less bleeding. There is less stress response, less bleeding. And this is not, by the way, not specific to regional for PIH. This is for any other patient, and you are telling something which is, you are not answering wrong. Okay. But be very specific. And then if you go for
increase, decrease risk of DVT, better hemodynamic of the perfusion of placental perfusion, sir, and sir, early start of the breastfeeding, and sir, early mobilization.
Yes.
And short.
Okay, so these are the things. Listen, this is a message for everyone. Whenever we are being asked for advantages of GA or advantages of regional, don't start cursing the other modality. Okay. You have to defend by praising the other rather than humiliating the other. Okay.
Okay.
So what are the problems with GA?
Sir,
now you can tell whatever you were saying, polypharmacy, airway manipulation.
Polypharmacy, sir, potentially difficult airway problems, sir. Is a risk of aspiration, and sir, risk of neonatal depression because of the opioids that impaired placental perfusion, sir.
And some of the complications of spinal versus epidural versus combined spinal epidural. You should be knowing that if you want to compare spinal versus epidural, spinal is better because there are less chances of epidural hematoma because the needle is smaller. Okay. And if you are considering epidural or combined spinal epidural, advantage will be that there will not be sudden hypotension. You can control the hemodynamics better as compared to spinal. Okay. So these are the things. And single answer, there is nothing 100% safe in these scenario. If you are doing one thing, there can be problem with something with the other. Okay. Now they will ask you this question about the numbers you have to see before giving spinal or epidural. So how much should be a platelet count, or how much should be INR for epidural or spinal?
Sir, in single short spinal, platelet should be more than 50,000, sir. And in
50,000, where have you heard this? Is it 50,000?
Sir, sir, I have read in FRCA.
Can anyone, and what about epidural? Yes, Dr. Sagar.
More than 80,000, sir. It should be more than 80,000. And for neurosurgery or macrosurgery, it should be more than 100, 1 lakh, sir.
You see, we are discussing PIH. You have named this mistake. You don't do in exam. Examiner will be thinking that he is just not focusing. Okay. We are discussing PIH. You don't need to tell about neurosurgery. Okay. So
sir, we have to. Sir, we have to see the trend.
Yes.
Trend of platelet count. But 100,000 is the safest for regional anesthesia.
100,000 or 7, because 50,000 I doubt. 50,000 is too low for spinal. I think it should be more than 75,000 for spinal and more than 100,000 for epidural, if I'm not wrong. Just correct me, because it can be different in different books and different places.
Safest is 100,000.
Just confirm it. Okay. If you have any doubt, try to be a little higher rather than low. Okay. Or you, for specifically for oral part, you can say risk versus benefit. Okay. You have to see the overall picture, not exact one number, as Rajanan told that you should be focusing on the trends rather than one number. Okay. And what else? INR should be less than 1.5.
And it should be less than 1.5. Okay, sir.
Okay. So
PTK and PT should be normal, sir, as well.
Yes. So the question will be on this fluids, as we told, that crystalloid versus colloid, and you should be focusing. You can use the word as goal-directed fluid therapy. You have to be meticulous. You should have to see the patient overall. And you have to if you are giving spinal or epidural, you can consider to give some colloid preloading because there will be exaggerated intravascular volume is decreased, so it can cause more of hypotension than normal. Okay. Blunting of stress response, we have discussed number of times. You can use some low short-acting opioids. You can use short-acting beta blocker, and even if you have to blunt the stress response. Usually opioids are being avoided, but in this scenario, if you fear that if you will not give opioids, patient can have severe hypertensive response. So you will give it and you will inform the neonatologist that I have given the opioid and you have to manage accordingly. Okay. So priority, as I told, that priority is for mother rather than baby. Okay. Because it's not at all a big deal. If you are using remifentanil, there will be no problem. If you are using any other opioid, you will use opioid to blunt the stress response and you will inform the neonatologist. Okay. And this question, that what thing you should be using for control of blood pressure? What you have to give for control of blood pressure?
Intraoperative.
No, I'm sorry, this will distracted me. My question was that how you should be controlling the hypotension or hypertension. It is hypertension. I write by mistake hypotension. Hypotension or hypertension in PIH patient intraoperatively. Hypertension we have discussed. Hypotension, according to the scenario, I think, what about comparison between ephedrine versus phenylephrine? Basic rule will be you should be giving.
We should avoid ephedrine in this particular in preeclamptic patients, sir. It should be phenylephrine or norepinephrine, sir.
Yes, sir, Salan.
Yes, sir. I saw or read somewhere that phenylephrine causes severe bradycardia, so we should have to avoid it, especially in
I tell you something. If you stop quoting specific words of a book, I guarantee you, you will have a better concept. Okay. Sometimes this is the major factor of failure. The thing which you are saying is also correct, and the thing which this one Atiq Bhai is saying is also correct. Phenylephrine causes more bradycardia in a pregnant patient. Okay, this is one thing. The other thing is that here, because patient is having this one main pathology here is this one reduced intravascular volume. Okay, so you are not telling about fluids. You have to use judiciously fluid. You are only fighting between ephedrine and phenylephrine, but you are not thinking that the pathology here of sudden hypotension during anesthesia, even if you are giving general anesthesia, not specifically for regional, there are more chances of patient going in hypotension intraoperatively once you give the induced anesthesia. When you secure the airway, you blunt the response, there can be sudden hypotension because these patients are volume depleted. So you are not using the word volume. You have to mention this thing as well. Okay. Other than that, you can use either of them judiciously with the end response. If the heart rate is more, you will be giving priority to phenylephrine. If heart rate is low, you can use ephedrine as well. There is no contraindication for ephedrine or phenylephrine. Anything can be used according to the scenario. Okay. But both of you are doing this mistake. You did not mention fluid. So you have to mention fluid as well. Okay.
Okay.
And among the uterotonics, the problem is with the ergot. So you will be avoiding ergot. Okay. So I think I have tried to cover as much aspects of PIH, eclampsia, diagnosis, organ system effect, control of different complications. If you have any comment or question, we can discuss, and then we will continue later on. Okay.
Sir, one thing they have asked me in the exam, sir, how would you monitor the, although you have mentioned it, but there are three things which I want to mention it.
Yes.
How will you check the magnesium level? How will you monitor the magnesium level, rather it would say. One is from blood levels, one is from urine, one is from ECG, one is from tendon reflexes.
Yes.
Maybe somebody.
Yes, you are right. It's like that. Anything else? Okay, everybody, thanks a lot. And all of you are welcome to contact for any question, any suggestion.
Sir, one thing I want to ask, sir, how will you, where you will manage the patient? You will manage the patient in HDU or ICU. And sir, extubation criteria is the same for as
yes. Thanks for mentioning this. I missed it. Of course, this patient might need post-op HDU monitoring. Okay, for the certain reason, for magnesium therapy, for chances of patient having pulmonary edema or any end organ damage. Okay, and extubation will also have the same things which are needed at the intubation. Okay.
And sir, they also asked me in sir, what type of although you have mentioned it, but again I want to say intraoperative monitoring in although we in Pakistan we don't do it mostly, but because of the urgency of the operation. But sir, intraoperative monitoring is very important in preeclamptic patients, especially very high, severe preeclampsia.
You know, anywhere where you are expecting swings of blood pressure, okay, it is better to have invasive blood pressure monitoring. Even if you have some advanced equipment, you can, even with the arterial line, you can monitor the fluid status as well, which these two things are required. CVP or cardiac output monitor. CVP is not the prime thing in anywhere. Even in resuscitation, CVP is not the first thing. Wide bore cannulas are the first thing. Okay, even if you want to see the fluid responsiveness, CVP is not the prime thing to do. In certain scenarios, if CVP will not be very accurate. But of course, you have to tell the name, CVP or pulmonary artery catheter in specific situations. Intra-arterial blood pressure monitoring, you can fit in any scenario. Wherever you have any doubt that there will be some swings of blood pressure, or even you want some invasive control of the hemodynamics arterial line, you can say. Okay.
Sir, last question, sir. Then you can finish it. What are the other clinical or indication for magnesium sulfate other than this preeclampsia, sir?
There are so many things. There are so many things. You tell.
Sir, there may be tetanus, there may be acute severe asthma, and there may be
resistant asthma. This one, as we told, even in cardiac arrest, okay, for corrective, for electrolyte imbalance correction, as even it is being used as membrane stabilizing, as antihypertensive, and as you mentioned, tetanus. Okay.
Okay, sir. Okay. Sir, is there any role of magnesium sulfate in neuroleptic syndrome or sir? Yeah.
Malignant hyperthermia, I don't know. Malignant hyperthermia, for what you want to give magnesium? For arrhythmias, you can give. Okay.
For stabilizing of the catecholamines, inhibition of catecholamines.
Yes. Okay, everybody. Thanks a lot for your presence, and we will discuss next topic in next sitting. Okay, most probably tomorrow. Thank you. Bye bye. Salam alaikum.
Thank you, sir.